right. Thank you for joining us this morning. I'm Rob Frazier, and I have the privilege of introducing our Grand Round speaker. Before we get started, I want to just thank our exhibitors, Amgen and Novo Nordisk, for being here and sponsoring us this morning. Today, I'm introducing Dr. Carolyn Bramante. She's an assistant professor in both the departments of internal medicine and pediatrics at the University of Minnesota. She did a combined medicine pediatrics residency at Johns Hopkins and stayed at Hopkins for her T32 clinical research fellowship, which included training and board certification in obesity medicine. Currently at the university, her clinical practice focuses on obesity management, as you would expect, and her research interests focus on remotely delivered interventions to improve weight-related outcomes in pediatric and adult populations. In addition to that, more recently, she's contributed to COVID-related research given the association between obesity and adverse outcomes. This work has included leading the COVID Out trial team. This was a randomized placebo-controlled trial evaluating metformin, ivermectin, and fluvoxamine as therapies for COVID-19, which was just published last summer in the New England Journal of Medicine. So with that being said today, Dr. Bramante is going to speak to us on anti-obesity pharmacotherapy for the long-term management of obesity. Please join me in welcoming Dr. Bramante.
All right, is Mike good? Yep. Thanks so much again for having me. And yes, I'm a general internist in the Division of General Internal Medicine, though we do have a new name now, which is Geriatrics, Palliative, and Primary Care. So just trying to make people aware of that name. And at the end of this talk, I hope you'll be familiar with all the anti-obesity pharmacotherapy options, and that you would be able to consider prescribing one of these options for patients and be aware of referral options for your patients. I have no personal financial disclosures. I am on a K-23 grant from NIDDK, which covers a large portion of my time, and I will be discussing some off-label use of medications. So I will go over some of the physiologic background of obesity, some brief basics about prevalence of obesity, physiologic responses to weight loss, and then really focus on the pillars of obesity treatment, and with the majority of the time spent on medications for obesity. So, we in obesity medicine, feel it's very important to educate around the complexity of this disease, the stigma of this disease. So I will spend a few slides at the beginning here really reviewing this for everyone. So obesity is a complex dysregulation in the body's energy regulatory systems. It's very multifactorial, very individual. It was officially defined as a disease about 10 years ago. And while it seems like this might be further stigmatizing, really, if you think about obesity as a disease, as a biologic dysregulation, it can help patients separate this from being accused of it being their fault, or it's just their behaviors. And it's also important for gaining insurance coverage for treatments. And in general, we try to never use the term obese, but rather say patients with obesity, like you wouldn't say cancer patients, diabetics, individuals with cancer, individuals with diabetes. I won't spend much time on this since, EPIC does this for all of us, but in some of these guidelines from the endocrine societies, there are differences that they are pointing out based on how obesity is defined in South Korea, China, and Japan. And I bring this up just to go over the guideline definitions, but also you may want to start considering referrals and treatments earlier in some patients. And this slide is just a brief visual of the complex gut-brain regulation in the body in all these pathways that affect obesity, satiety, hunger, And some of the medications that we have now can disrupt these dysregulated pathways in the body so that good behavior changes have a chance of working. So that's how we think about this in the obesity medicine world. And this is just another slide to show how complex and how many transmitters and receptors are involved in the regulation of how much adipose tissue we have in the body. And what causes extra adipose? These are very multi-layer, complex factors that are largely outside of someone's control. So, societal level issues, community level, built environment issues, access to food, all the way down to experiences in the uterus, causing epigenetic changes in individuals, microbiome we've all heard about. So there are very complex factors that affect our degree of adiposity. And this list of
recording stopped.
Different
Recording in progress.
Types of, that's okay. And similarly, there's felt to be several causes of obesity and distinct phenotypes of obesity. Some, the monogenic diseases that we learn about, but these are extremely rare. I've never seen a patient with any of these single gene diseases, but there are many different causes of obesity for each individual. All right, so briefly, it's also an important cause of health disparities. This dark blue bar is non-Hispanic white individuals in the US as of 2021, non-Hispanic Black, Asian, though if we use criteria in countries in Southeast Asia, this bar might be a little bit taller, and then Hispanic. So we can see there are many important factors influencing social determinants of health related to obesity. And it's obesity stigma is very pervasive when individuals with obesity interact with the healthcare system. There have been multiple studies on this. One of my mentors in fellowship was an obesity stigma expert, and it affects individuals at every point in their step of interacting in clinic, how the staff that's checking them in might treat them, whether or not the clinic has chairs to accommodate their size. I had one patient tell me once in residency that the only reason they weren't feeling suicidal during that hospitalization is because we had gotten them a bariatric bedside commode. So it's very structural, the challenges that people face when they have a larger body size. All right, and why is losing weight so hard? Well, we've adapted over thousands and thousands of years to not let our bodies lose weight. So this was a rapid weight loss study that was undertaken just to see what changes happen in the body. So they rapidly induced a 30-pound weight loss, so over 10% weight loss in these individuals, and then watch their hormonal changes over the following year. And you can see that once someone lost a large amount of weight, there were changes in their hormones to make them regain weight. So their ghrelin, the main orexigenic hormone, went up. So that's the hormone that makes us want to eat. And their appetite-suppressing hormones went down. Now you can see that over time, these hormone levels did come closer together. And so that is one of the indicators that we see clinically, is that after you're able to sustain a weight loss for a number of months, the body does seem to finally have a new set point, which some people call it, and stop trying to regain that weight. All right. So these are the most recent Obesity Society guidelines focus on these 6 areas: behavioral changes, reduced calorie diet, increased physical activity, sleep, stress reduction, and medication management. I highlighted reduced calorie diet in red, just to say in your notes, you want to say the patient has been following a reduced calorie diet, not a low calorie diet, because insurance will look for reduced calorie diet, and low calorie diet is not required by guidelines, and so you don't want to give your patients the impression that they have to follow a low calorie diet like 500 to 1,200 calories. So starting to think in the ways of an insurer when you're documenting is important. And then I'll go through each of these pillars very briefly, and I'll spend most of the time on medication management. One of Minnesotan, actually, Angela Fitch, she's now out at Mass General. She put this together for a paper we wrote together. And you can see here what patients can expect from the different levels of intensity of obesity treatment. So behavioral interventions generally will get 5% weight loss at most. Meal replacements and prescriptive nutritional interventions will get 5 to 10%. Pharmacotherapy gets us up to over 10%. I would say often over 20% now. There are some endoscopic procedures, and bariatric surgery is still considered the most effective and most enduring form of weight loss, but the medications are getting so good that this also might be changing. So in the end, I'll summarize some of these points to say what I think would be an efficient way to interact when specialists are starting a weight loss discussion with a patient and referring. And one of the things that I think would be helpful to highlight for individuals is that sleep is actually very important for weight regulation. When we get inadequate sleep, the body raises cortisol levels, ghrelin, the main orexigenic hormone. And so increasing sleep quality and quantity is a very important way to improve weight. And I'm sure in cardiology, you're often referring people for sleep studies if you have any concerns of OSA, but also just spending a few moments on sleep hygiene and specifically reducing exposure to artificial lights at night is very important for weight management. So this study followed a cohort of women for decades, and exposure to artificial light was a huge cause of incident and prevalent obesity. So spending a moment talking about increasing sleep is one thing to consider. And when patients come to see us in clinic, it's often one of the first things we talk about because it's hard to be compliant on medications and dietary recommendations when we're sleep deprived. Sleep medicine, of course, is its own important field as well. And so if you have someone who has very challenging sleep circadian dysregulation or very challenging work schedule that involves night shifts, you could consider sending them to sleep medicine as well. So dietary changes, I'm not going to talk about that more than just the one slide because really I rely on our colleagues our nutrition colleagues to counsel patients on specific changes to make in their food consumption. But this is just an interesting recent article that shows that the type of diet really doesn't matter. Low carb, low fat, the genotype that we think might predispose people to doing better with a low fat or low carb diet really doesn't matter. So the main thing is reduced calorie intake, and whatever is a sustainable way for someone to achieve that is what is most important. And what works for someone might change over time, right? So for a period of time-restricted eating, only eating for a certain number of hours every day might work for a patient, and that might change over time. So obesity is a chronic disease, and it deserves frequent follow-up and reevaluation if weight gain is not happening or if weight regain is happening. Physical activity is actually the least important initial intervention for weight loss. Physical activity is always a good thing for other reasons, sleep, mood, all the health benefits from it. But as a weight loss intervention, they have actually randomized patients to dietary interventions only, physical activity interventions only, and the physical activity intervention arms don't lose weight. So it is something that I usually don't talk about at all in my first visit with patients, other than to say, we'll talk about physical activity in the future. For now, just focus on sleep and medication. By the time someone has come to me, they're really interested in starting a weight loss medication. But eventually, you'll want to increase physical activity. It's also much easier to increase physical activity when you've already lost 15% of your body weight, and then it does become very important for maintaining weight loss. Behavior interventions, again, this is a whole talk in its own. I will bring up just one behavioral intervention, which is self-monitoring, so tracking food intake, physical activity. These are all tools in the toolbox for maintaining weight. If you told everyone that they have to track their steps, track their food, track their weight, and medication, sleep, diet, it would be overwhelming. So we keep these as things to introduce over time when patients hit plateaus. And self-weighing is something you probably use in the cardiology world a lot for fluid status management, but it is effective for weight management alone because that awareness improves self-efficacy is the behavior change theory. And that daily weighing, this is a poor quality figure, but daily weighing is more effective than weekly or monthly weighing. And in adults, many studies have studied psychological impacts of daily weighing, and in adults without active eating disorders, it generally does not cause psychological harm. All right, so jumping into the medications for weight management. There are now a number of FDA-approved medications, and I'll go through each of these. I'll say Tirzepatide or Mounjaro is not yet approved, but it's been fast-tracked to be approved for obesity management, and it's currently FDA-approved for diabetes management. Phentermine, Topiramate, naltrexone, bupropion, these are combination medications of existing generic meds for other uses. And in weight management, we prescribe these individually or in combination. In combination, they're often more expensive than if you prescribe the two components individually. And often Phentermine alone or Topiramate alone will cause a lot of weight loss in and of itself. But the two combination medications here potentiate each other so that the two combined causes more weight loss together. And lastly, Phentermine is technically FDA approved for short-term use for obesity, so 3 months or longer than 3 months with a meaningful pause. But there is a large trial underway to prove that long-term use of Phentermine is safe. So this may be changing in the future. All right. One of the most important things is to avoid unnecessary weight gain promoting medications. And many of these we are not going to manage, like antidepressants and antipsychotics. But I will just say in cardiology, avoiding beta blockers when possible is important. I do have patients who come to me from primary care who are on beta blockers as a first-line hypertension treatment. That's been happening less and less, but I will do an in-depth history, call their provider, and if there's no cardiovascular need for a beta blocker, I will work with the primary care provider to take them off of a beta blocker. And then in the obesity medicine teaching, we're taught that carvedilol is likely less weight gain promoting than metoprolol, for example. So if it doesn't matter from your standpoint, if you can start with carvedilol, for example, that is a little bit better for weight than other beta blockers. And then systemic antihistamines is another one that is underappreciated, but does cause weight gain. So if these are being used for allergy management, we try to get patients to use localized symptom management instead. This is a rough order of effectiveness on weight. So Tirzepatide, the new medication that is not yet FDA approved for obesity, semaglutide, liraglutide, Phentermine, Topiramate, bupropion, naltrexone, Metformin, Orlistat. Minnesota Medicaid now covers all anti-obesity pharmacotherapy for both adults and children, so that's really, really wonderful to get that insurance coverage for patients. And I'll have to put in a plug for a shout out to faculty at the U, like Claudia Fox, Erin Kelly, Justin Ryder, who did a lot of advocacy with the state legislature to get this coverage. So you can prescribe Wegovy for patients on Medicaid, adults and children, and it will be covered. So this slide is just a brief overview of some of the cardiovascular risks and benefits of obesity pharmacotherapy. These are all the GLP-1s above here, and this is a very busy slide, but in general, cardiovascular outcomes are improved with the glucagon-like peptide-1 receptor agonist. There was an insignificant, minimal potential increase here with semaglutide, but otherwise, these medications have great cardiovascular outcomes, as does metformin, although very minimal to insignificant effects there. And then SGLT2 inhibitors, we don't use those for weight loss unless we truly have no other options, but they're very favorable in the cardiovascular world now too. The other medications, the non-diabetes medications, this is an overview of their cardiovascular effects. And I will get into these, a few of these later on. Lorcaserin is no longer approved for use. It was the trade name Belviq. So just so you're aware of that. All right, so Tirzepatide, this article was published in New England Journal this summer. And so this is Mounjaro. It's a new GLP-1 GIP dual agonist. And the way it works is by, I'll get to that on the next slide, but you can see the degree of weight loss is very impressive with this medication. So even on one of the lowest doses, participants were receiving a 16% weight loss, and the higher doses, the degree of weight loss was even more. And what you can tell patients is that, for example, 76% of people on the 15 milligram dose will get more than 15% weight loss. So the majority of patients on these higher doses are going to achieve over 20% weight loss, and a third are going to achieve over 25% weight loss with just one medication. In the weight management clinic, we will often combine medications as well. So someone could be on Tirzepatide and Phentermine, for example, or Tirzepatide and Topiramate. So really the potential for weight loss through medication management is getting more impressive every year. So Tirzepatide is a GLP-1 plus GIP receptor agonist. So basically the GIP potentiates the effect of GLP-1 on appetite suppression and some effects on both the gut and the brain signaling related to metabolism and the drive to eat. Most patients tolerate this medication very well with really no side effects. It's just a once-a-week medication, so it's very reasonable to, oh, this is a typo. This should be 2.5 milligrams weekly. It's a weekly medication. And there is a slight increased risk of gallstones in the GLP-1 receptor use. It's unclear if that's an effect of the medication or just an effect of the greater weight loss, because we do see gallstones with weight loss over 10-15%. Pancreatitis is very rare. We don't really counsel that it's a side effect, but if someone has a known history of recurrent or chronic pancreatitis, that would be a contraindication to the GLP-1 in the combo medications. The other main contraindication is a family history or personal history of medullary thyroid cancer, but not other types of thyroid cancer, so not papillary thyroid cancer. And the dose titration, there are a number of dosing levels here, which is great. And you increase the dose only once a month, so not more frequently than that. So you, in cardiology, let's say you have a patient who needs to lose weight pretty quickly for a heart transplant. You're going to refer them to weight management, but you really want to help them get weight loss started. You could prescribe the starting dose of Tirzepatide. There is no follow-up monitoring needed. Unless someone's on insulin, then their risk of hypoglycemia does increase slightly, but this medication alone does not cause hypoglycemia in someone who does or does not have diabetes, so there's no monitoring required. Semaglutide is similar. Oh, I reloaded this figure several times. I'm sorry it's blurry, but you can see still a very robust and impressive weight loss with this medication. So at over a year, the sustained weight loss is again over 15%. And this is again a weekly medication. All the GLP-1 receptor agonists, so Tirzepatide and semaglutide and Liraglutide, come as injections, but we have demonstration pens in clinic. Our Novo colleagues have demonstrations out there today, and you can show patients how tiny the needle is. And when you show them that, even if they were initially reticent to use an injection, most adults and children are fine with these tiny little needles. And if someone still has a lot of fear about the use of a needle, you can advise them to take an ice cube and rub it on their skin for a few, like 20 to 30 seconds, and that numbs the area briefly. And then most patients can tolerate it, and over time they don't even need to do that anymore. They can give the injections to themselves or have a family member give the injection. And so this is the same side effect profile as Tirzepatide. This is the single GLP-1 receptor agonist. I have very, very few patients have any side effects with semaglutide. Again, it's once a week. I'm sorry for that typo. And it's extremely efficient for them to start it. And most patients will start losing weight on just 0.25 to 0.5 milligrams. And I will say for all the medications, I titrate to effect. So while you could increase the dose at 4 weeks for each of these doses, if someone is already losing weight on 0.25 or 0.5, I have them stay on that dose until the weight loss effect tapers off, and then I increase the dose. And now that I've run a big multi-center trial myself, I realize it's nearly impossible to write a clinical trial protocol that says, okay, if a patient is doing this well, you can have their dose be this, and then so an individualized protocol is very hard, which is why the dosing regimens are what they are. But in reality, these lower doses are often very effective on weight. And so I've had a number of patients who lose over 100 pounds over the course of years, but we just increase the dose as needed. Sometimes they're on a dose for 6 months before we increase. Again, no monitoring. So if someone's on insulin, they should be counseled that this, in theory, would make their risk of hypoglycemia greater, but but really the cause of the hypoglycemia is the insulin, not the semaglutide. And semaglutide has been in the news this weekend on NPR. Ozempic face was talked about. So Ozempic is the name for the diabetes dosing, which used to be 1 milligram. It's now 2 milligrams. Wegovy is the name for the obesity dosing. And I really do not think that the Ozempic face has anything to do with the medication itself, but just the really effective weight loss that people see with using this medication. And all the celebrities take it now. So actually, I have mentioned to a few of the celebrity names to patients, and that was what made them definitely want to take it. So. All right, so liraglutide was an earlier generation in the GLP-1 receptor agonist family. It was the first GLP-1 officially FDA approved for obesity, but some of the even earlier cousins like Trulicity, Bydureon, those also caused weight loss. But so this is Victoza or Saxenda are the trade names for diabetes and obesity, respectively. And again, this is really impressive weight loss, over 8% over a year. And a third of patients are going to achieve over 10% weight loss with this medication. And the vast majority will achieve over 5%. And this medication is daily. And while you can increase the dose every week, I usually increase the dose at least every 2 weeks to avoid any side effects and to prolong the weight loss. So I've had a number of patients lose way more weight on this medication, but again, we titrate to effect. So we start at 0.6 for a month, then 1.2 for a month or two, and usually on 1.2 milligrams, patients are starting to lose a lot of weight with Saxenda. Side effect profile, the exact same as the previous two medications. This medication is a little bit more likely to cause side effects, I think only because it's the daily formulation. But I have patients I have very few patients who get side effects. I think it's probably because I do dose titrate it every 2 weeks or longer. And one nice option about this medication is that it is daily, and it doesn't affect sleep. None of the GLP-1 receptor agonists are stimulants, so they don't affect sleep at all. So I have patients who prefer the daily liraglutide over the weekly injections because they really struggle with afternoon and evening hunger, and so they want this daily injection to help them get through the afternoon and evening. So this is another great tool in the toolbox of obesity treatments. And injection, again, with the tiny needles I showed. All right, and I'll spend a little bit of time on the older obesity pharmacotherapy as well. But now the vast majority of what we're prescribing is the Saxenda, the Wegovy, the Mounjaro when it's FDA approved for obesity. But like I mentioned earlier, we use combinations. So someone could be on Qsymia and Wegovy, for example. So this is the main efficacy study for Qsymia. Qsymia is a combination of Phentermine and Topiramate. And these are the different doses. You can see Phentermine alone, Topiramate alone in the combination. And the side effect profile, so Topiramate is a carbonic anhydrase inhibitor. Most patients tolerate it well. You know, it was originally designed as a anti-seizure medication, but it's most often used as a migraine prevention medication. On higher doses, so once you're over 100 milligrams a day, it does seem to slow cognition and cause word-finding difficulties, but we often get a lot of weight loss at lower doses, so 25 to 100 milligrams a day. And the neurologist for migraine prevention will use really high doses, 400 milligrams twice a day. So there's a huge dose range. You can even cut these in half and have 12.5 milligrams. And the main, and kidney stone, I'll just say the risk of kidney stones is really increased only in individuals who already have a history of calcium oxalate kidney stones. But if someone doesn't have a history of kidney stones, Topiramate does not increase that risk. It is the one anti-obesity medication that is actually teratogenic. It's very rare, but it can cause cleft palate. So this is you definitely want to talk about that with women of childbearing age, and make sure they are aware of that and are on contraception. And then Phentermine, so of all the 6 medications, and there's more than 6 if you separate out the combination medications, Phentermine is the only medication that's not repurposed. It's the only one that was made specifically for weight loss. Everything else I've talked about and will talk about is repurposed from another indication. So I think that's just an interesting thing to think about with obesity in general. It's an extremely common chronic disease, but yet has very few therapies dedicated to it or designed just with obesity in mind. Because it is a stimulant in the amphetamine class, there's a lot of concern that Phentermine does cause elevated blood pressure and tachycardia, and I'll show you some data in the coming slides that don't support that. I will say I have seen early symptoms of serotonin syndrome if patients are on other serotonergic agents. So you would definitely want to counsel about that and probably not use Phentermine if there's a potential risk there. And there is a huge dose range here as well. The smallest tablet is 8 milligrams. You can cut that in half and have just a 4 milligram dose up to 37.5. I had a patient come to me who was already on 37.5 twice a day, and they were doing well. So there's a pretty large dose range here. So this is some data about effects on blood pressure with Phentermine is the white, placebo, Phentermine, Topiramate, and then these are different doses of Phentermine, Topiramate, and really over a 1-year follow-up, blood pressure decreases in people on Phentermine. So while we think that, yes, it might cause increased blood pressure, that doesn't seem to be the case in most individuals. This is a prospective cohort of an EHR cohort. But like I mentioned, there's now a large randomized trial with long-term follow-up. And then this is change in heart rate. So heart rate does go up by a beat and a half per minute. And then this is really, really messy, but just another visual of Phentermine. So this first panel is all patients with Phentermine, so effects on weight, effects on heart rate, heart rate is here, and then blood pressure. So blood pressure really goes down for most people, heart rate goes up, and then those effects were largely the same in individuals with normotension at baseline, with pre-hypertensive backgrounds, and with hypertension at baseline. So interestingly, people who have hypertension, their blood pressure and heart rate don't go up with Phentermine, potentially because they're already on a hypertensive therapy in their monitoring. And this is without Phentermine. All right, and then I'll put in one quick slide about Metformin. Metformin would be considered off-label for weight loss, but we do use it a fair amount in adults and peds, and it does cause weight loss itself. With all these medications, people respond in different ways. As we all know, medicine should be individualized, and some people, I have some patients who respond very well to metformin with and lose 40 pounds with just metformin. So it's very interesting. It does seem to lower appetite for about 5 or 6 hours after you take it. So if we're using it in someone with overweight or obesity, whether they have diabetes, prediabetes or not, I usually say don't take it right before bed because then you're going to sleep through the appetite suppression of it. And in our COVID trial, early outpatient treatment with metformin prevented over 40% of ER visits, hospitalization, and death. And in our 10-month follow-up that just finished last month, it also prevented over 40% of long COVID diagnoses. And then briefly, bariatric surgery. Again, you would obviously refer a patient to a comprehensive weight management program, but this is some of the data from randomized trials showing how effective bariatric surgery is for obesity treatment and for type 2 diabetes treatment. And overall, the rates of complications are very low with bariatric surgery. There's the Roux-en-Y gastric bypass and the vertical sleeve gastrectomy. The bypass has a little bit more weight loss, but it does have more side effects and potential for long-term nutritional deficiencies than the sleeve gastrectomy. But one thing you can say to patients is that we're referring you to, or, if they're interested in being referred into weight management, it doesn't mean we're referring you just for bariatric surgery. There's a range of options: behavioral, dietitian, medical weight management, surgery, and it's really up to the patient to engage in what aspects of those treatment options they want. And then just briefly, there are some endoscopic treatment options that have come in and out of favor. The Aspire is actually no longer FDA approved, so this was a reverse G-tube basically, but this is another area of obesity medication, but it's a rapidly changing field. Briefly, if you're seeing any patients with cardiovascular complications before pregnancy, you really want to counsel them on how much weight they should gain during pregnancy, because a huge cause of obesity in women is peripartum and intrapartum weight gain. And anyone know the number of pounds to gain during the first trimester of pregnancy, or someone who's starting with a normal BMI? No. 25.
We're all too old. 25.
It's like in the first trimester, even if you're starting with a normal BMI, it's like 0 to 5. If you are starting off pregnancy with overweight or obesity, it's 0 pounds of weight gain in the first trimester. Total weight gain for a woman with normal BMI is 25 to 35 pounds. Total weight gain with higher BMIs depends on comorbidities as well. But especially if you, it's a tough conversation to have. I have the luxury of never having to diagnose obesity or have that really sensitive, challenging conversation, because by the time people come to me, they all have realized that they have obesity and they want to treat it. And just to emphasize that it's important in clinical care of someone with obesity to make stepwise changes, to not overwhelm them with all the potential treatment options, or to not recommend all treatments at once, but really meet them where they are, make a few goals about medications and behavior changes, and have frequent follow-up. And again, we really push physical activity later, but it's joyful and fun for people to engage in physical activity once they've lost 15% of their body weight, and it's something they usually bring up on their own at that point because they're excited to move more and they can move more. So I'm going to go through one patient example that I hope illustrates some of the things that we can do in a weight management clinic setting. And this was for a patient. I won't talk about a patient who needed a heart transplant because the cardiology community, I don't want to give away any PHI, but this was a patient who needed a lung transplant. So he had non-specific interstitial pneumonia on 10 liters of oxygen. He needed his BMI under 30 for lung transplant. Really impressive guy, still working, single father of 3 teenagers. And so he came to me in the weight management clinic from his pulmonologist. This was a number of years ago, so before we had Wegovy and Tirzepatide, and he had already lost 27 pounds on his own. So that first weight loss is sometimes the easiest. So then we come in and often help patients once they've plateaued a little bit. We did start Metformin. He had a history of prediabetes and low-dose Victoza. And I asked his pulmonologist, I said, how long do we have with his lungs? When do you think he'll really need that transplant? And his pulmonologist said September 2019. So this patient and I mapped out a roadmap of what his weight should be every week between December 2018 and September 2019. And so he started to lose weight with those medications that we started. We kept the Metformin at 1,000 milligrams. We increased the Victoza. We played around with the time of day that he took the Victoza. He's continuing to lose weight on these medications. He's sending me his weights once a week just to keep himself accountable. Then we did a twice daily dosing of Victoza, and he had pretty bad hypertension, so I was somewhat limited in other medication options that I could use for him. But this seemed to help him get over a plateau. So now he's lost from 330 down to 270 at this point, so over 60-pound weight loss. We tried Topiramate. He did not tolerate it. We were behind on the weight loss schedule we had sketched out. Then we added daily weighing. So we added daily weighing at this point, 4 months into our work together. And the daily weighing alone helped him really restart some weight loss. So at this point, he's down to 255. He's lost, 70 pounds now, 80 pounds. And that was pretty much all we did. We added a tiny dose of Phentermine later on, and he was able to meet his transplant goal of a BMI under 30. And he'll add in daily tracking of food on an app when his weight is creeping up, and he's able to see that weight gain because of the daily weighing. So again, this is Metformin, Liraglutide, and a tiny dose of Phentermine, and he actually got his weight well below the goal of 230s, so well over 100-pound weight loss. He got COVID pre-transplant, and he did fine. He didn't even get hospitalized for it, I think because he was on Metformin, to be honest, and then he did receive a transplant and is doing well. So that's an example of a very, very acute need for weight loss, and we often can get there even in those severe need situations. So I don't know, there's multiple comprehensive weight management clinics here in the metro. The phone number for the MHealth Fairview one is there. I don't expect you to manage obesity yourselves, but especially if you have someone who needs a transplant or has really bad hypertension or really bad effects from their obesity, I would recommend getting them started on improving their sleep, evaluating for sleep apnea, obviously, and then you could even definitely start one of these top 3 medications that are very effective for weight, very safe, have great cardiovascular outcomes. And even if you just prescribed that starting dose and they're on that dose for 2 or 3 months by the time they see us, that's already a great step forward in their treatment, and then we can take over from there for dose escalation or adding other medications as well. And just like you would for diabetes or hypertension, don't just tell someone they have the disease without offering treatments or referrals for it. So same thing for obesity. You know, a lot of patients are really deflated psychologically when they come to us saying, my orthopedic doc said I can't have a knee transplant until I lose 20 pounds, but he just told me to walk more and eat less, and luckily I found your clinic. You know, so give them treatments. We have many evidence-based treatments now, and that's a big insight that I get from a patient advisory panel I meet with every 2 months. They say it's a sensitive conversation, but they want their providers to tell them about obesity treatments. So, time for questions, I hope.
So you've got lots of treatments that seem to be very effective. Do you ever get some patients off these medications? You get to goal and get off medication?
Yeah, good question. You know, I've only been on faculty 4 years, so I haven't had that long with any one patient yet. I had a patient who lost over 100 pounds with Liraglutide, then semaglutide, and then she lost insurance coverage for it. And she was able to maintain weight, but she really wants to be back on a GLP-1, and we're working super, super hard to get her back on that. But what we tell patients is that this is highly individualizable, so we can adjust all of this to meet your needs. You can stay on these medications indefinitely. You can go off of them. You can go down to maintenance dose. So the great thing is that it's super individualizable to what they need and want. You could restart them if they did regain weight. So.
You started by talking about the fact that obesity is a disease and not necessarily altered behavior, and yet in the example that you provided, it was actually their altered behavior that led to some of their greatest weight loss. How do you reconcile those?
Well, I think it's both, right? So I don't think if I had told him here, start weighing every day, it would have been overwhelming and deflating. But part of what drives us to eat, palatable foods is some of the adipokines that interfere with leptin receptors in the brain, for example. So I think once you have less adipokines in the body, you have less of that interference with some of your natural satiety regulation, and then it's easier to make effective behavior changes. But you're right, he did lose this 27 pounds purely on his own. He was also super motivated. It was a life and death situation, but it's both. It's super complex. It's super hard disease. It's probably one of the most visually stigmatizing disease, right? You can't hide that about yourself. Everyone can see your BMI essentially, and so I think we as medical providers have to just not further that stigma that people are already receiving. It would harm we know it harms their obesity treatment. It also harms their uptake of other treatment like cancer screening and whatnot. So it's complex, I think. But yeah, I have many other examples, but this was my one non-heart transplant example. Yep.
Is there any lab values that you're monitoring with their weight loss?
No. Other than just general screening for diabetes, cholesterol, following up on those as needed. I will do vitamin deficiency screening once someone loses over 15 or 20% weight loss. Surgery, it's very clearly laid out, the monitoring, but I'll do that for medical weight management as well.
Dr. Bramante, thank you very much for your presentation. We do have several online questions. I know we're getting close to time, so maybe we can just see how many we can get through. The first two actually have to do with insurance. If you could just expand a little bit on that. Dr. Burke specifically asks, What percentage of patients are covered by insurance for these medications?
I don't know. It seems to change all the time. Like I mentioned, Medicaid now covers it in the state of Minnesota. Medicare does not. Private insurances vary a lot, and it's all changing now in the new year. And I think as we have new therapeutics and such proven efficacy with Liraglutide and Semaglutide, so I have no idea. But always make sure to document all the efforts that patients have made, because insurance does seem to limit access based on efforts in diet and exercise.
Well, thank you for that. Another question is, at your practice, do you try to wean patients off of their weight loss medications once they reach target goal weight, or is it, you're gonna be taking this medication indefinitely?
Yeah, again, it's super individualizable, and most patients who I see have a very high BMI, and I've only been practicing for about 4 years, so no, I haven't actively weaned many patients off yet, but it does happen that after a few years of weight loss, a nice slow weight loss, 1 to 2 pounds a week, and maintaining that weight loss, that patients just have less drive to eat. I think that's the reset of the adipose mass and fewer adipokines interfering with satiety receptors.
Sure. How about, are there any approved electrical stimulation therapies for weight loss?
Yes, so this area is changing as well. The phrenic nerve stimulation is not widely done yet, but I think those are coming and being developed. But I have not had any patients receive those.
Excellent. Well, maybe we just do one more online question, if you don't mind. And that question would be, so what kind of weight gain or rebound have you seen in any of these patients, specifically any patients that stopped their GLP-1 RA agents?
Yeah, so that definitely does happen, whether they fall out of contact with us or they lose insurance coverage. And I haven't had a patient regain to their starting weight, and from a physiologic standpoint, that seems to matter. You really want to try to keep the weight below the starting point. So I've had patients who've lost 15% on a GLP-1 and then gained back 5% when they've had to go off it. And while they're unhappy about that, they've maintained many of the health benefits from that residual 10% weight loss, and then we can restart and get them losing again.
Thank you.
Thank you for